I love gout. Such an interesting disease. I hate it for the people because it's terrible, but it's so interesting. Okay, so what have you learned about gout? Uric acid crystal formation. So, and what is what's the crystal shape or the composition crystal, chemical crystal?
It's the gold.
It's a monosodium urate, and and I'm telling you that because when you read literature and stuff, it'll say MSU. They won't spell all that out, and they won't say uric acid crystals. They won't say urate crystals. They'll put MSU. Okay, what else? Good. Common for the big toe. Why is the big toe the common temperature? So we'll talk about solubility and saturation points because that chemistry comes back into that. So cooler temperature, furthest away. Okay, what else? So, okay, so we'll talk about that because the guidelines say 6, less than 6, and I'll talk about why that's the case. So hyperuricemia, different definitions. Some will label it as 6, some is greater than 7. We'll talk about it as 6. We're going to do that. I'll give you a justification for that too. What else? Why is that?
It'll or make it worse.
Why does it make? Yeah, that's true. Why does it make it worse? Okay, so
Step.
what?
I remember that's the rate limiting step in actually the
It's the rate limiting step in what? Okay, so that goes to mechanism. So we'll talk about why during an acute attack you don't want to start that. So we'll talk about that. Okay, good. What else? Did you just have this or was this yesterday? Last week. Oh, okay. Did you get tested over it?
Yeah.
Really? Okay.
This is good. We can review.
Okay, what else?
You prescribe allopurinol and colchicine.
So allopurinol is one of the drugs you can use, yes. Colchicine is one of the drugs you can use. It doesn't have to be colchicine. It's a good drug. It can be hard on the body, but it's good. Okay. So, and what were you saying? You can prescribe what first? Say it again. Colchicine first for what?
The acute.
So it can be used for acute.
Right.
Okay.
Like to try to clear the crystals.
What other drugs can be used in that same approach? You only talked about that. So there are more. They're telling you their preference. It's not bad. It's not bad, but it does have its downsides. Okay. What are the side effects of colchicine? Okay. It's all right. What else? It's good. You've remembered a lot. So when you start them on, it's a continuous treatment. They don't get better. You have to continue to give that. Okay, so that's a lifelong, indefinite, we'll say. Anything else?
Prevalence increases in age.
Prevalence can increase with age. Who fares better or worse, men or women? Men are more likely to have it. Okay. All right. What else?
On the allopurinol, Dr. Venata said most people treat 300 milligrams, but she could go to
So he taught you about it. Yes, yes, internists like colchicine. Okay, say it again.
That most people dose at 300 milligrams, but you can go up to 800 milligrams.
You can go to
Undertreated a lot because people don't.
Okay, so usual is 300. Did you talk about how to start it, how to dose it when you start? Okay, we'll talk about that. You can go up to 800, just depends. Renal insufficiency will sometimes limit how much you can do. What else? Very good.
Pseudo-gout?
Pseudo-gout is not gout.
Yeah.
What does it do to? CCPD, what does it stand for? So it's one of your differentials. So when you are working up an acute joint inflammation, it's one of your differentials. What would else be your differential in an inflamed joint comes in? No other history. So you've got gout, you've got pseudo-gout. What else? So a septic joint. Okay, what else? Say it again. Could be rheumatoid arthritis. Is rheumatoid usually, how many joints are usually involved in gout? One. In rheumatoid, how many are usually? Multiple. So those are kind of start to give you a clue. They tend to be more upper extremity, fingers. Gout tends to be lower extremities, but not always. Okay.
Pseudo-gout can affect the knee, right? Is that
Yes.
why some people think RA? Because
Yeah.
RA can do knees?
So how can you tell the difference? Aspiration. Do you know how many people will let you come at them with a needle when their joints are inflamed? Very few. If you can get it, it would be good. What?
Sunrise X-ray of the knee.
Sunrise X-ray of the knee. To show you what?
The calcium deposits.
Oh, for pseudo-gout. Okay. Okay. I don't know that. I'll go with what you say. Okay. What else? What else in your differential?
I would say turf toe. I had turf toe one time and it's the worst.
Okay, so in inflammatory, so you got to think inflammation.
And it was red and swollen.
It sure does, yes. And that would be, but you're young. You would be awfully young to have gout. The other would be like psoriatic arthritis, tenosynovitis. I mean, there's lots of inflammatory, but the big things would be gout, pseudo-gout, septic arthritis, psoriatic arthritis, and I'm leaving one out. Not rheumatoid. Did I say rheumatoid?
Yes.
Yeah. I blanked. So lots of things. So the one thing you do want to make sure is it's not an infection before you stick a needle in it or put some drug in it, right? Okay, good. All right. Okay, very good. So on the very first page, I switched and reorganized the handout from the way I did it last year, and I forgot to take that little note in the front off that said the drug details are on the back. I moved them more to where they were in therapy. I didn't know, I didn't look to see who was doing this, so I gave you a lot on pathophysiology. So we'll just kind of go through that and see. I don't know how much time he spent on it. Did he do more clin med? Did he do pathophys? I had this in there last year, so I'll go through it quickly. Let's just to refresh. You all remember a lot of this. Let's just look at this.
Is a chronic crystal deposition disease that is the most common inflammatory arthritis. Evidence of gout is rising. This is potentially due to trends such as increasing age, obesity, and
There's
lifestyle
what I
factors.
term the black mail.
In most patients, gout is caused by inefficient renal excretion of uric acid. Increased excretion of uric acid leads to hyperuricemia, or elevated uric acid levels in the blood, causing urine crystal deposition into joints, organs, and other connective tissues. Gout and hyperuricemia are independent risk factors for hypertension, CVD, CKD, and diabetes, and have been linked to obesity and osteoarthritis. In humans, uric acid is the natural end product of purine metabolism. The production of uric acid comes from two sources: the degradation of purines during normal cellular metabolism, and the breakdown of dietary purines in the gastrointestinal tract. Most uric acid produced by the body is eliminated by the kidneys, and the remainder is eliminated by the gastrointestinal tract. Within the kidney, the glomerulus filters the blood. The resulting filtrate passes through the proximal tubule, where over 90% of uric acid is reabsorbed back into the blood. Multiple transporters, including URAT1 and OAT4 in the renal tubule system, are involved in uric acid reabsorption. URAT1 is one of the major transporters in the renal proximal tubules and reabsorbs most of the filtered uric acid from the lumen, thus maintaining overall uric acid homeostasis. In humans, uric acid levels are regulated by a balance between uric acid production and elimination. In most patients with gout, hyperuricemia results from inefficient renal excretion that may be due to alterations in transporter function. Alterations in transporter function results in higher serum uric acid levels in gout patients. When uric acid levels rise above the serum solubility limit, monosodium urate crystallizes out of the serum and deposits in joints and soft tissues. These crystals, or microtophi, may not be readily visible without special imaging. These crystals can continue to build up for years. Eventually, and without warning, an immunogenic event occurs, triggering a powerful inflammatory response. the patient experiences an acute flare of gout. Acute gout flares can be caused by many factors, including joint trauma, dehydration, and fluctuations in serum uric acid levels. Acute gout flares can last several days and usually resolve spontaneously. Without urate-lowering therapy, continued deposition of monosodium urate crystals may lead to visible tophus formation. Crystals in and around bony surfaces can perpetuate the inflammatory response and cause permanent bone and joint damage. Management of acute gout includes drugs to suppress inflammation, reduce pain, and hasten recovery time. Following an acute attack, the likelihood of recurrence is high, up to 60% in the first year. Patients that experience frequent recurring flares may require urate-lowering therapy to protect against recurrent episodes and prevent the development of tophi, which can lead to chronic destructive arthritis. Gout is usually treated through a combination of pharmacological or non-pharmacological means, including caloric restriction, reduced alcohol consumption, and dietary modifications. Long-term pharmacological management of progressive or recurrent gout aims to reduce serum uric acid levels to less than 6 milligrams per deciliter, or in some cases to less than 5 milligrams per deciliter. Unless serum uric acid levels are lowered below the saturation point of monosodium urate, crystal deposition may continue. Maintaining low serum uric acid levels prevents crystal formation and deposition and promotes crystal dissolution.
Ring familiar? Did I bring my old one? Okay, so pathophys, let's walk through some of these. What I'll do is I'll point out the points of this where it links to drug therapy. Can you see that okay if I leave the light on, or would you rather I turn the light on? Okay, so starting on the front part page, page 2. So one of the most common rheumatic diseases of adulthood, you will see this quite often. A lot of drugs induce it. So as people get older, that if they are at risk, it will probably, it will show up a lot more. So hyperuricemia, so high uric acid levels are, or above normal, are required to have gout. But you can have high uric acid and never get gout. So there are other things that go in there. You know, we have up to, I'd say the last few years, we have treated gout, we have done the flares, and then we know that over time they get chronic arthritides and sometimes have uric acid stones, or we can cause a problem with chronic kidney disease because of gout or uric acid deposition in the kidneys. But what they are now understanding, as people understand more cytokines and inflammatory process, they have now nailed it down to the cytokines that are involved. I don't know if you all talked about that part, but I'm going to bring it in because there are some investigational drugs they're looking at to address that. So this would be akin to us just, if you think about asthma, where you've got a chronic inflammation in the airway. And occasionally what we see are flares, right? We get exacerbations of the asthma and we treat those, but we recognize that there's an underlying process going on in the airway that if we don't treat it, we'll get chronic progression of that disease and the flares will continue to happen. That's kind of how we've done gout, is that we've treated the flares until they get to arthritides and then we treat that. So now people are starting to recognize what is going on in those joints from an inflammatory response. And so now much more, I think in your lifetime, I keep telling you that, but you're gonna see changes. I think much more we will treat it as a chronic inflammation. We won't just treat it as an acute disease and then eventually we'll worry about the complications of it, okay? So I think you're gonna see shifts to more biologics over time that as they develop, that will help arrest that, that chronic inflammation that those sodium crystals bring on. Probably that crystal deposition starts and on goes for years before people have their first flare. So maybe even 5 or 10 years before. So instead of just treating that acute flare, I think eventually once people declare themselves, we will go much more aggressively to maintain the joints and to prevent bone erosion, because that's the worst. That's one of the worst things, is that you get a bony erosion just like we saw with RA. The other is that the kidneys can really become infected or affected by constant uric acid deposition, and it can lead to chronic kidney disease. So that being said, so hyperuricemia, where to draw the line? In the past, it's been above 7. People were looking at more when do people usually get gout? Well, you rarely ever see gout below 7%, uric acid of 7 milligrams percent. You just don't. And a lot of that goes to the solubility of uric acid in the blood. So let's look at that. So you remember this concept from chemistry. So we're looking at a crystal in blood is the main thing. So an unsaturated solution is when we can continue to add uric acid to the blood and it doesn't precipitate out, right? But saturation point is when you got the maximum amount of solute in a solvent and it stays in solution, right? So for uric acid, that is about 6.4. So you could conceivably start to see precipitating out and those crystals moving once you get above that. So from what I have read, because I had put it in the handouts, one place I had 6, one place I had 7. So I moved back after I've read some different folks' opinion. I think we ought to call hyperuricemia anything above 6. If he gave you 6.5, but I've not seen that show up in any of the guidelines. Yes.
In the PANTS practice book, it's 7.
I'm sorry.
Oh,
I don't know what to tell. I'm telling you. Here's what I think. People still do 7. So if they give you 6 or 7, I don't know what to tell you. If they're going to make you split hairs like that, I don't know. But I'll say that there is a good reason to say it's 6. However, it is not agreed upon across the board. For my discussion with you, I'm going to say 6. But 7, if that's what they've got, that's standard in some areas, so that's probably why. Okay, so saturation. So that's one reason for the 6. That's one of the reasons why I'm going with that. The other is solubility curve. You all talked about this. So as temperature increases, solubility increases, right? So that's why the toe, or the furthest away from the core, is most likely to be affected, and that's what we see. Now, any good Southerner knows this, because when you make tea, can you get sugar to dissolve in cold tea? No, you have to warm it up. If you put sugar in warm tea, does it go into solution? Yes. So just remember that simple concept of trying to dissolve sugar in cold or warm temperature. When I first started going to Alabama, if you order tea, you always got sweet tea. It's only been in about the last year or two that I've started, when we go to a restaurant and you order tea, is they'll ask you, or they'll say, it's sweet tea. And so they've even started to have to adjust because of all the Yankees that have, that come down. You know, Yankees, for Mark, Yankees is anybody above Birmingham. They do. They consider the north part of the state Yankees. Like where all the, what's the place where all the arsenals are? I'll think of it in a minute. They're mostly Yankees from the north. That's the way they look at it. Okay. So most common joints, you all have got them. I have never seen it in the shoulder. I'm sure it can occur. Wrist, I have seen, not very often though. Elbow, you can see big tophi coming into the elbow. Mostly it's going to be toe, ankle, and knee will be your most common presentations. Okay. Never seen in the ear as they show down there in that picture. Oh, I didn't put it in slideshow. Okay, I'm sure he showed you some pictures. This is a common presentation, commonly what it's going to look like. Redness, swelling, you can tell an inflammatory process is going on. And there's tophi. So if uric acid goes, or if high uric acid stays long enough, you will see tophi. And those are unsightly, they can be painful. If they get into the kidney, they're really causing trouble. We can treat now and get rid of tophi. We have some drugs that are pretty powerful that will allow those tophi to reabsorb or resorb. There's x-rays. I'm sure he showed you x-rays of them. What do you see in the joints? You can't see the uric acid, but you can certainly see tophi. So what do you see in the joints that are affected? What happened to the joint space? So how have you been told to approach a joint on x-ray? Have y'all talked about that? So the joint space in a lot of those is destroyed. You see some granulomatous changes around there. You can see, it's probably too small, but you can see erosions. So that would be in a chronic, you wouldn't see that probably early on, but when people have repeated attacks, you're more likely going to see those changes. There's a kidney with several stones here. You see the renal pelvis is all inflamed. So you can imagine the problems that person had in kidney function. So we want to avoid that. So that's another reason to be fairly aggressive, especially if people give you a history of stones. So you would want to know if they come in and they've got a joint that is inflamed, one of the things you can ask them about is, do they have a history of kidney stones? And if they do, then you want to ask them what kind. Most of the time people will know. Uric acid, calcium oxalate would be common ones. So ask him about uric acid stones. Okay, let's walk through this. This is the common life cycle of a person with gout. So initially they will have, if you've looked at their uric acid, you may find it's elevated. So usually the higher the uric acid, the more likely they are to get gout. Did you all talk about that, the escalation? I worked for an endocrinologist for a number of years at the VA, and his cutoff was above 10%. We treated everybody, if they were asymptomatic, we treated them, because your risk at above 10 is about 30%. It drops off quite a bit when you get down to 9%. I wrote these down because I didn't have it. So from around 9%, 9 to 9.9, it's about 15% risk. 8 to 8.9 is 5% risk. 7 to 7.9 is 1%. So this is why we don't treat asymptomatic hyperuricemia. I would suggest when you get to around 10, you need to think about it. If you cannot get it down in any other way, they are more than likely going to, they're at great risk for experiencing gout. All right, so asymptomatic hyperuricemia is going to be will persist for years. And people may stay, especially if they're in that 7 to 8 range, they may stay there forever and never develop gout. This is on page 3. So then we get to this where the acute flares, then they declare themselves. So maybe something happens. Maybe they drank a lot of alcohol. Maybe they were put on a drug that then increased it. Diuretics are infamous for raising uric acid levels. So thiazides and furosemide can do that. So they will interfere with the ability of the kidneys to get rid of the uric acid, so blood levels will go up. So maybe they're put on a drug, then that is what pushes them over, raises it high enough that then they develop an acute flare. I would consider at this point that when you see this, you think about it as an acute flare on top of a chronic process that's ongoing. That process has been in place a long time, and now we're just seeing it to the point where it clinically declares itself. Then they go into what they call these intercritical periods. These people can go a long time. They may have a gout attack and not have one for another year or more. So those intercritical periods can go for a long, long time. But usually most people will go on to have another attack. It's usually about 60% at least will go on to have another one. If they start to have more in a year, then we start looking. The criteria says if it's 2 or more in a year, then put them on uric acid lowering therapy. As they progress in the disease, those intercritical periods will become short. So the time between flares will get shorter and shorter. And it reflects that chronic inflammation that's going on, and the deposition of those crystals just continue. Okay, and then we get to advanced gout where we've got complications. So a gouty arthritis, you've got bony erosions, you've got disruption of that joint, and also the kidney. So tophi, chronic gouty arthritis, and then nephropathy, sorry. So those would be your 3 big complications. This is a picture, I didn't put it in your handout, but I like this one because it gives you another visual of the progression. And you'll see that the time between flares can be as long as 5 years or more, and that as they progress, those intercritical period times become much less, and then you have established advanced disease. Everything pretty much consistent with what you heard by Dr. Banana told you. Okay. So let's come back to page 4. So you've got it down that uric acid's the end product of purine metabolism. So purines are going to be your proteins, so you can see they're your organ meats. What's an organ meat? Liver. Okay. If you're an African American population, what might they tell you? So gizzards. What else? Sweetbread. They eat pancreas. Pretty common. Kidney would be another that people might eat. Liver. So all of those, the organs, intestines. Anchovy, shrimp, sardines, scallops, game meat, gravy, beer. Sorry. Beer higher than wine. Wines will also do it. Okay. So you talked about this. You talked about hypoxanthine converted to xanthine, and xanthine then converts it to uric acid. And you mentioned that enzyme, xanthine oxidase, which one of our drugs targets, allopurinol, is a rate-limiting step. In Most animals don't develop gout because they can go ahead and metabolize it on down to allantoin, which is a water-soluble, no problem, get rid of it by the kidneys. And we have drugs that will actually help the person do that. That are like uricase, which is another enzyme that will help metabolize the uric acid on down to the allantoin. So you talked about overproducers and undersecretors. Okay. You can actually measure uric acid production in a person if you're really unsure. Most people don't do that. Most are going to treat whatever the symptom. Most people are undersecretors. You're not able to secrete the uric acid back into the proximal tubule. So overproduction, that excessive de novo purine synthesis is related to a genetic disease. It is rare. Excessive dietary proteins are probably mildly contributing. The big thing is alcohol. So telling people not to drink alcohol if they have gout is appropriate. Alcohol interferes with the excretion of uric acid, so it's fairly, it can be significant, but in the whole scheme of things, it's still a minor cause. Excessive nuclear protein turnover. Now this is important if you're going to deal with cancers. Sometimes when you get rid of a big tumor load and you are getting rid of a lot of cellular protein, it gets converted to uric acid. So these people can have a significant uric acid levels. And so in those people, we would treat usually with a very high allopurinol you're talking about, like the 800. You'll see that dose more common when you're treating those myeloproliferative disorders than when you are treating gout. Most patients with gout are going to need in the 200 to 400 range. But when you get into those large cellular tumor loads, those are the folks that need that usually higher dose. That is my experience. Did you all talk about that, cancer-related uric acid? Okay. Under secretion on the next page, this is the major problem. So most uric acid is going to be eliminated by the kidneys. So you can see why age is part of it. So as the kidneys go down in function, their ability to get rid of uric acid is going to go up. The other problem is that it relies on secretion. So secreting, and we're going to walk through this, but secretion is a major pathway for our eliminating a lot of drugs. So a lot of drugs that are renally eliminated, the way the body gets rid of them is they actually secrete them. It's not filtered through the glomerulus, but it is secreted from the blood into the proximal tubule. Okay. So that's why drugs are a common cause of high uric acid and precipitation. So let's talk about these 4 phases. Did you all talk about the elimination? Yes? No. No. Okay. Well, I put this slide in. I don't know how accurate it is, but there are some things it does that I like. One is that uric acid is a fairly small compound. And so it gets filtered 100%. So whatever's in the blood gets taken out. And it's filtered at Bowman's capsule, enters the proximal tubule. If you look on your, in the middle of page 5, it's walking you through the same thing. It's just that they tend to infer that some of that happens in the loop of Henle and distal tubule. I do not believe that's true from what I read. Most of this is occurring in the proximal tubule. So what happens, 100% gets filtered, but then the body reabsorbs. So you have these transporters, that OAT transporters and the urate transporters, and these move the uric acid out of the proximal tubule back into the blood. That's the first or second phase, actually. So almost 100% of it gets put back to the blood. So that's what it's showing in number 2. Then what happens? Crazy things, because those transporters are active, they transport it back into the renal tubule. So you see there about 50%. So here we are to that third arrow where it says 50 to 52%. So these transporters, as the blood's going by all those proximal tubule cells, are going to transport it back into the proximal tubule again. So now we're back to the urine. Then what happens, because those transporters are still active, they will reabsorb it back into the blood again. This is important because different drugs will interfere with these processes at different points. We also take advantage of this and use drugs to enhance or block reabsorption. Okay? So we have drugs that are called uricosuric agents. Okay? Uricosuric means that puts uric acid into the urine. Okay? So we use some of those to help us. If we can't use a xanthine oxidase inhibitor, we'll use a uricosuric. All right, so in the end, we only excrete about 10% of what we filter because we reabsorb it, we secrete it, we reabsorb it, and finally we get rid of it. That is an important process you need to know. It'll make other things and other drugs effects make more sense. Questions about that? I have to rethink it all the time when I am working with the drugs, or I've got a drug that's precipitating problems. I have to make myself walk through it again. Okay, this one is on page 6. So this is a proximal tubule cell. This is the urine filtrate. So imagine that above that sign that says urine, that's Bowman's capsule. So that's all the filtrate coming down. Also imagine that there is another proximal tubule cell on this side. I think they make it harder to interpret this picture. I like what they did. But you've got, this is the proximal tubule coming down, this, or the lumen of it, this is another cell on the other side. Of course, there'd be one on this side too. We're looking at it in just 1 or 2 dimensions. Okay. So what I want you to appreciate here is you've got these these cation and anion transporters. And they're all of them. There's a multitude of them in these tubules. And they are moving stuff back and forth all the time. The two that are important to us are this urate and these OAT receptors. So the urate receptors, what they do is they move uric acid out of the lumen and back into the cell. So they're part of the reabsorption process. Then there is another little receptor called, I think it's GLUT9, and it moves it on back into the blood. So what urate does is it takes it out of the lumen and puts it into the cell, and the cell gets rid of it into the blood through another transport molecule. So you see that probenecid above it? Probenecid is a uricosuric. We can use it to block that transport process. And we can increase the urinary excretion of uric acid by doing that. Now it has some limitations, and so that's why I don't know if Dr. Benetti even talked about it, but it certainly has its role. On this side, you see these OAT receptors. They're responsible for secretion. So when we get to the secretion part, we're going to move the uric acid from the blood back into the renal tubule. That's those processes. So you'll see aspirin can block that. So aspirin at low doses can block secretion. So if you've got people who you really are having trouble controlling their gout and they're on aspirin, you're fighting a losing battle. However, it's dose related. At high doses, higher than mostly we tend to see people take nowadays because we've got other non-steroidals. High dose aspirin blocks this side. So if you're in the 2 to 3 or 4 grams of aspirin a day, it's working over here. It will actually help you get rid of uric acid. Low dose blocks this side and will increase uric acid levels. So if you've got somebody who's got high uric acid and they're on a low dose of aspirin, it's probably contributing. Now you have to weigh what's most important. If they're on a low dose for cardiovascular protection, then you may just have to work with trying to get rid of the drug in another, or the uric acid in another way. Let me stop here. Something I didn't put in your handout, but I did want to bring to your attention. Did Dr. Venata talk about uric acid being an indicator of cardiovascular disease? So we've known for a long time that diseases, complexes, or groups of diseases tend to occur more often in people that have other diseases. So if you look at glucose, lipids, hypertension, uric acid, people can come in with each of these being a single disease, can they not? Can people not come in with just, we would say you've got high cholesterol, or they have hypertension, or they have diabetes. It's rare that they will have this and not these others. So what we're actually seeing is that these are part of, I didn't quite draw this well. If you consider this an iceberg, what you're seeing here is just the tips of the iceberg. They have a unifying problem in the end, which is insulin resistance, which we'll talk about in endo. This has been known for a while that uric acid, gout, tends to be more of a problem in people who also have those other diseases. But I haven't seen it called a major cardiovascular risk factor, but I've started to see more people drawing attention to that. So when you see people who have gout, also look for cardiovascular disease, or think about that. Usually they will have multiple complexes. They'll have other things. But what I want you to appreciate is that these diseases are related to each other in a way that isn't always apparent. But insulin resistance, metabolic syndrome. Did y'all talk about metabolic syndrome in cardiovascular? Okay. Metabolic syndrome also has its root in insulin resistance. Questions about this picture? Here's your aspirin. So here is high dose, they're saying 3 grams, about 2.4 grams a day is the threshold, I believe. Uricosuric, low dose, 75 to 2 grams, will interfere with secretion. All right, let's see this. Okay, top of page 7, secondary causes. So obese people tend to be more likely to have an excessive alcohol intake. Beer increases your risk by about 1.5 times. Diabetes, hypertension, so those things that I drew over there on the page. Medications that raise uric acid, you should know these because they're common. Thiazide's very common. People have it, you put them on thiazides, and the next thing they're calling you is, my toe is so big and I can't walk. Low dose aspirin. Now cyclosporin, tacrolimus, you're not going to see those as often because they're going to be more with they're huge anti-inflammatory immunosuppressants. History of kidney disease. So, sorry, your kidney stones. I guess we disturbed the people in the I did with the URs the other day, so I didn't know that they could hear me. Chronic kidney disease, genetic or acquired causes of uric acid overproduction, those are rare. But these other things happen often. So when you see those clusters, look for stuff. You have somebody who's got that high risk for cardiovascular disease, diabetes, hypertension, lipids, common triumvirate. Then look at their uric acid. So definition, hyperuricemia, I think you've got this, it's not gout. We're going to call it as 6 grams per, or milligrams per deciliter is what we're going to use for this, these lectures. The next ones are just definitions, so definition of gout, an arthritic condition resulting from deposition of monosodium urate, so the MSU crystals, in or around joints, bones, soft tissues, following long-standing hyperglycemia. And then the tophi or tophus is the deposition of those uric acid crystals on joints or the surface of cartilage. Let's see, I think. So the crystals, we talk about solubility. The other thing I want to talk about is what is now known about the role of the inflammatory response. So those urate crystals in the synovium evoke an inflammatory response, but not in everybody. So you will find gout will tend to run in families. So if somebody has gout, they may tell you, my dad has it too. That is not uncommon. So a genetic predisposition seems to fall to that. The cells that are involved are the ones you've seen in all the other inflammatory responses we talked about: neutrophils, monocytes, macrophages, lymphocytes. Okay? So when those uric acids, when they evoke a response, those macrophages go to the site. And we have some drugs that we can use to keep them from moving. That's what colchicine does, keeps those macrophages from being able to move, or phagocytize. So they phagocytize the crystals, and then there is a, like we've seen in other inflammatory responses, you get a cascade of response that leads to then the development of inflammation. So have you ever heard of inflammasomes? I hadn't, because I was looking back. I hit something that caught my eye, and so I thought, okay, I'm going to look and see what I can find. So these inflammasomes are part of these NLR receptors, are part of the sensing operation of the immune system. So the native immune system is always watching everywhere. Every space you've got, every organ you've got, you have the immune system, which has these toll-like receptors, and they have these NLR receptors that are sensors. They're just watching for inflammation, damage, mostly pathogens to show up. But if something, or a cell that is self that doesn't look right, or a cell that's proliferating, like with cancer. So you've got this constant sensing, and so that's what those receptors are. They're associated with these activating proteins and this enzyme, which I'm going to show you in a minute how it plays a role. So when you have some type of, like we'll say the uric acid, it will activate and cause this ASC, this Cas base, and these NLR, and this is the main, there's lots of them, but these three will form a complex. So it's this pretty little pinwheel. When that pinwheel or that complex forms, it activates that enzyme that I talked about, that Cas base, and it will convert, then that enzyme converts these two interleukins, pro-inflammatory, 1 beta and 18. And they become activated, and this one, this interleukin 1 beta, is the primary cytokine in gout. It's important because people are starting to look at agents that block that, and I'll show them to you at the very end. I think in your lifetime, that's what health drug therapy will head. It'll head much more to biologics than what we're currently doing. Because what we currently do is ineffective, and we're usually the horses out of the barn before we ever start treatment. Okay? So the one big thing to remember is that interleukin 1 beta is the primary cytokine, and that these inflammasomes are key to initiating an immune response. I think you'll hear more about them. The more I dug into them, the more, there's a lot known, They just don't tend to rise into our, I think, our education at this point unless you're looking more at inflammatory diseases at this level. Okay, so I'm going to play, listen. So I'll play this video and then we'll take a break. Okay, how do I get it? This doesn't have sound for a while, so this is that important sound. Isn't that cool? Of course, the cell dies. It's interesting, they talk about the death domains of these different cytokines and products. Cool, and it doesn't really. Okay, we'll take a 10-minute break and then we'll come back and we can talk about the drugs.